So let's come over to the talk of the day, that is the metabolic triple alliance to reduce blood pressure and protect organs, focus in Asia Pacific region. So what is the triple alliance? The metabolic triple alliance refers to the interconnected cardiorenal metabolic care, which is needed because of the combined symptoms which makes it as a syndrome where cardiovascular disease, kidney disease, as well as metabolic disorders form a dangerous triad that amplifies the health risk and actually they amplify each other's in severity. These three conditions are interconnected and amplify each other's progression through shared pathophysiological mechanism. Like once we talk about the synergistic effect that is coming through the mutual amplification of the organ damage. If a person is already having the kidney damage, rarely he dies of the kidney problem. Most of the time he dies of the cardiovascular adverse outcome. Common risk factors, if we talk about the insulin resistance, is the mother of all evils, which is also giving rise to the hypertension, also responsible for obesity, also responsible for the diabetes, and all the metabolic disorders are taking their soil of origin from the insulin resistance. Obviously, ending up with the chronic inflammation, which is yet to be handled, and we are getting the newer molecules which are focusing on the chronic inflammation. So unified treatment, integrated approach is needed now. And this concept has started from the Steno 2 that you only don't need to treat diabetes, you need to treat the dyslipidemia, diabetes, and hypertension together. Then only you can save your patients from the complications. That is coming up in a different shapes because now we are having the molecules which are addressing all the three molecules together, all the three problems together. So let's talk about the burden in Asia Pacific. 1.3 billion hypertension patients are in Asia Pacific, which are badly controlled. Out of that 35% suboptimal management, and 130 millions are the diabetes patients. 40 million of them are the CKD patients having the chronic disease burden. So when we talk about the epidemiological challenges, they may be very much different in this Asia Pacific region. Asia Pacific region's challenges, where we see that hypertension control is not more than 30 to 40, 35 to 40% individuals as compared to the Western nations, it is much higher. Their causes are resource limitation, poor medication access, poor healthcare, and many of the times people don't reach to the healthcare. And more of that, I would love to say that this is because of the poor information. We are not able to tell our patient that what is needed to do. That's why they stop the medications before and they don't continue it for the time when it should be continued. And many of the times we are not really clear for how long to continue, like Dr. Lily was just saying that if we have started the melatonin, for how long we should give it. So the question is unanswered because until unless you control your circadian rhythm and make it to the normal, what you are not going to have, because we are not going to change our habits. So obviously we have to take it throughout the life. So core pathophysiological drivers could be, obviously the insulin resistance is in the it in the root of this, which is the central mechanism linking all the three pathways. And these core pathophysiological drivers, we understand that RAS activation, which is responsible for the high blood pressure, and it promotes the kidney damage and other end organs damage, including the neuronal damage. Oxidative stress is the thing which is most important, is started even 10 to 15 years before the diagnosis of the diabetes, and it just starts damaging the endothelium and cells. So endothelium dysfunction that triggers the pathology of the atherosclerosis, it starts in a patient with diabetes about 10 to 15 years before the occurrence of diabetes, and when the person is diagnosed of the diabetes as per the current cutoff. So these two things are well appreciated and well known to each and everyone, and we are having the molecules to have these RAS activation and oxidative stress to manage. But what we do not have to do anything, that is the chronic inflammation, which is the product of all these two, three things, and that perpetuates a vicious cycle. So insulin resistant, which is the central mechanism linking all the three, RAS activation, chronic inflammation, as well as oxidative stress, these are the four pillars for this damage which may come up in the form of the end organ damage. CKD and CVD progression in type 2 diabetes is driven by the combined effects of the metabolic, hemodynamic, and inflammatory fibrotic factor. So we all understand that hemodynamic and metabolic. Hemodynamic is well taken care by the RAS blockers. Here, hemodynamic is well taken care by the blood pressure management. Metabolic is well taken care by the diabetes control, and of course, the anti-diabetic medication plays a good role in that, including the SGLT2 inhibitor and GLP-1 receptor agonist. While the SGLT2 inhibitor is the drug which is working in both condition even for the hemodynamic management as well as the metabolic management. But what was the unaddressed, that is the inflammation and fibrosis. MR overactivation is actually the responsible for the inflammation and fibrosis in type 2 diabetes. We have seen that mineralocorticoid overactivation contributes to the CKD progression. So here we are having the molecules which can inactivate the MR activation. So cardiovascular impacts is the left ventricular hypertrophy, endothelial dysfunction, atherosclerosis risk, heart failure, for which we have already discussed in the previous slide. But once we talk about the renal impact, this is hyperfiltration, which is reflected glomerular stress and its damage. Albuminuria, which is occurring because of the protein leakage through the urine. EGFR decline is a progressive functional loss of the kidney, and nephropathy, which is occurring in patients, those who are having the diabetes alone, hypertension alone, as well as together. They presents with the nephropathy, and these are the outcome of this triple metabolic alliance, what we see once they are occurring together. Let's talk about the metabolic dysfunction. Hyperglycemia, we all know about that. Most of the time, our all focus remains on the control of the glucose. Dyslipidemia, of course, in this particular set of the patients, we see that hypertriglyceridemia with other lipid abnormalities. In India, we get the low HDL kind of the issue in this kind of set of the patient. Obesity, which is one of the important factor of the metabolic syndrome. And earlier we were not having many things to do other than the lifestyle modification for the obesity. So in that case, we were helpless to do many more or much more over the lifestyle modification. Insulin resistance, which is responsible for the progressive worsening not only of the sensitivity of the insulin, but also it ends up and takes us slowly and slowly towards the organ damage, which most of the time patient does not appreciate, and many of the time even clinician also does not appreciate until unless it reaches to the endpoints. So what are the key parameters which could be responsible for the clinical diagnosis? Of course, blood pressure is one of them. We have established that 140/90 mm of mercury has been the standard target threshold, but now this threshold is also getting changed, especially the people, those who are having all the three problems together, hypertension, diabetes, CKD, blood pressure required to be kept at less than 130/80. HbA1c, of course, it reflects the diabetes management, but again, in this Asian Pacific part of the world, we have to define the utility of HbA1c again because of the big number of the people in this part of the world are suffering with anemia, especially when a person is having the CKD. Already HbA1c could be helpful in those patients to detect that diabetes is at what level. EGFR, kidney function, via a CKD API formula. Of course, we can use that, and we are using it for knowing about the progression of the kidney damage. But the albuminuria or UACR are the investigations which can be done easily at every clinician's clinic. Every clinician, every doctor who is treating the patients with diabetes, hypertension, very easily can do the UACR, and he can do at least albuminuria. And if you are finding a patient of the diabetes or hypertension with albuminuria, it gives you an extra alert that treatment is not only mandatory, treatment should be done through the RAS blocker, SGLT2 inhibitors, as well as those molecules. When GLP-1 receptor agonist has also been found to be reducing albuminuria significantly. So treatment should be addressed with those molecules which are focusing on the albuminuria, so that patient can be slowed down to its speed reaching to the finally kidney damage and other complications. ADA 2023 guidelines recommended reducing very high albuminuria levels to slow CKD progression. In people with CKD who have more than 300 milligram per gram urinary albumin, reduction of 30% or greater in urinary albumin is recommended to slow CKD progression. And that is actually we need to do. So once we are having the one single condition, either it is metabolic or it is hypertension or it is albuminuria, we can say that patient is ending with a low risk. But if the two conditions are there, a moderate risk, and all the three are there, then patient is a high risk. So what is really needed? Early detection that can be done by the critical albuminuria screening in most of the clinics in country. Baseline establishment should be for the renal function and proteinuria status so that we can know when we are starting the treatment what is the EGFR of the patient. And as I already said, that most of the patient those who are having the kidney problem, even when those who are not having the kidney damage, they die because of the cardiovascular adverse and outcomes. So comprehensive evaluation should be done of the cardiovascular risk assessment. Let's come over to the integrated treatment approach. How can this integrated treatment approach could be achieved? Of course, lifestyle modification should always be the root of all our efforts. It should be the foundational intervention for all patients. Then it comes to the pharmacological intervention, which could be cardiorenal protective agents. Depending upon which problem is to be addressed, first we should choose logically the pharmacological agent. Then monitoring and titration, protocol driven optimization is required, and a protocol should be formulated for all Asian countries and Asian Pacific countries so that this can be taken up in every clinician's clinic to reach out to maximum level of the protection in the patient those who are having all the three problems. Multidisciplinary care team based approach has multiple times discussed and it should be there. So non-pharmacological intervention, if we focus on that, weight reduction is one of the most important. 5 to 10% loss improves outcomes significantly. And we have seen the patient, those who are having 5 to 10% loss of their weight, they become non-hypertensive, they become normotensive after some time. And this has been proven in a digital twin study which has been done in India and in Indian population. That study has been done in the leadership of Dr. Shashank Joshi. And for one segment, I have also participated in that. Dietary modification, low sodium, high fiber nutrition plan, of course, nobody would be disagree with that. But Indian population, I'm not talking about the other Asian population, but Indian population, it has been proven that our sodium requirement is comparatively much lesser than rest of the world. Physical activity, 150 minutes per week minimum. This is the internationally accepted. We have not reached to any consensus what should be the minimum physical activity for the Asian Pacific countries. Of course, the smoking cessation is needed. RAS inhibitors are the cornerstone of the therapy. So when we talk about the RAS blockers, we if we start them at the right time to the right patient, 22% events of the MI, stroke, CVD death could be reduced, which has been established in the HOPE trial. It prevents albuminuria. This could be the first line choice in the patients with diabetes, with hypertension, as well as CKD with hypertension, as well as if nothing is there in the hypertension. But unfortunately, if you do the survey of our country and what we have done through the Indian Society of Hypertension, we could find still in our country, 60% clinicians use calcium channel blocker as a first line agent for the hypertension management. So why do not follow the guidelines what they are saying, and why we do not want that our patient may not go to the may not be protected from the damage of organ. Let's come over to the game changer molecule of the decade, SGLT2 inhibitor. SGLT2 inhibitor is not only the anti-diabetic molecule nowadays, now it can be given to the non-diabetic individuals also for the protection of kidney, for the protection from heart failure, as well as reduction in the cardiovascular. 38% cardiovascular death reduction could be seen in cardiovascular mortality benefits of the SGLT2 inhibitors. 35% heart failure hospitalization could be reduced in users of the SGLT2 inhibitors. So benefits span metabolic, cardiovascular, renal domains now approved beyond diabetes management for broader CRM syndrome treatment. Let's talk about the GLP-1 receptor agonist. Of course, it is a molecule which has been introduced for the glycemic correction, and it has done the glycemic correction in its best possible way, and at the same time, it is giving us the benefits of the weight reduction. Weight loss has been achieved by the users of this molecule significantly. Cardiovascular event reduction, because many things are associated with the weight loss. Cardiovascular reduction as well as other things are coming if we are already weight loss, losing the weight, may it be with GLP-1 receptor agonist or without GLP-1 receptor agonist. But if we are doing it with GLP-1 receptor agonist, definitely we are getting some proven cardiovascular benefits. Of course, with the renal protection, emerging nephroprotective effects are being seen with the GLP-1 receptor agonist, where we could see that the users of the GLP-1 receptor agonist could get their more walking ability. It also improves the peripheral disease in the peripheral vascular disease in the diabetes individual. At the same time, we could see that GLP-1 receptor agonist has also helped in reducing the albuminuria. MRAs. This is the additional protection. Figaro-DKD trial has established a phenomenon demonstrated significant renal and cardiovascular benefit, which are beyond RAS blocker. So this could be the additional protection beyond RAS blocker. So already you are doing the RAS blocker, you are doing your maximum, but still you think that your patient is not doing good. This should be the additional option to add up it. If your patient is running with the hyperkalemia, keeping the potassium level more than 5, then this is the time you bring it down less than 5 and then start the finrenol. CKD efficacy, blood pressure reduction is not seen with the finrenol, but for the blood pressure reduction, we are having the separate MRAs which can be done if you have already achieved through the RAS blockers the blood pressure achievement, blood pressure reduction, then there is no point of adding any such MRA which can further give the reduction of the blood pressure. But if you think that you need further reduction of the blood pressure, then your choice can be changed towards the aplerenone and others MRAs. What could be the spironolactone and aplerenone? These aldosterone antagonists are actually responsible and indicated in the congestive heart failure, resistant hypertension, heart failure, and left ventricular ejection fraction is less than 40%, then you can get the best advantage of the aplerenone. But once you talk about the finerenone, even when your patient is non-hypertensive, patient does not have hypertension and you want to keep him away from the cardiovascular morbidity as well as you want to stop the kidney damage, the finerenone could be the best choice. Holistic treatment approach of the CKD involves different pathways to slow the progression of the heart and kidney disease. So obviously we understand the utility of the RAS blocker, we understand the SGLT2 inhibitors, and we understand the finerenone. What left, we have also discussed the benefit of the GLP-1 receptor agonist for the metabolic control, and this comes through the reduction in the weight. So recommended drug combinations could be the first line dual therapy, RAS blocker combined with the SGLT2 inhibitors. If you are having a patient who is having diabetes with albuminuria or diabetes even without albuminuria but hypertension, add MRA if needed. Inadequate response requires the additional protection in MRA is, I already said, what could be the conditions where the MRA is to be considered to add. GLP-1 receptor agonist addition is for the extra benefits of the metabolic as well as cardiovascular adverse outcome. Fixed dose combinations can also be chosen, especially in this particular part of the Asia Pacific, because the poor adherence is seen in this part of the Asia Pacific, which could be improved by the fixed dose combination, making the regimen more and more simplified. So, finerenone reduced USER by 32% between baseline and 4 months. And this lower means USR with finerenone could be compared with the placebo. And our requirement was the 30% only as per the ADA recommendations. And this molecule is giving us more than what we were requiring, 32% reduction in the albuminuria. Challenges in Asia Pacific. Let's talk about the what the challenges for which we have to fight. Limited affordability, poor access, disparities in the healthcare, awareness problem, cost effectiveness, obviously remains a big issue in the pockets of the individual. The region faces unique obstacles that impede optimal CRM syndrome management and treatment adherence. So medication affordability is the issue which is to be needed to taken care. Healthcare disparities is the next issue, but the biggest issue which should be taken care knowledge gaps. If we can fill up this knowledge gap, patient will automatically himself will go to the healthcare agencies to take care best of the possible take care. They will stop going to the weekend hotel and weekend dinner dates. Instead of, they will be knowing that this we are going to the adverse situation. We are kidneys are at the stake. We are going to have the cardiovascular adverse mortality. So they will be looking forward to afford the high affordable medication also, but these medications should be also tried from our side to come in the reach of the most of the individual. So let's, what could be the strategies for a better outcome? One, affordable treatment. We should expand the access to the essential medication. I always believe if we start using the right treatment in the right patient, affordability comes. Once you are using a molecule by majority of the people, then obviously its cost comes down. If you remember, once the ciprofloxacin has been introduced to the earth, it was very costly. Even don't go in that early when you think about the uh, gliptins. When they have been introduced, they were having the 50, 60, 70 rupees, which was looking like unaffordable for the majority of the people. But now everybody is using that. And their lesser cost versions are also prevalent in the market. We can get a 3 and 4 rupees also. So better use, more use is always the key of affordability, which comes in the any economic system. Screening programs, public health initiatives for the early detection. It should be told to each and every clinician whether he is member of RSSDI or member of Indian Society of Hypertension or not, that if you are looking any patient who is having diabetes coming for the first time to your clinic, it is mandatory to check his albumin in urine or check the USCR. Education initiatives are again should come from the physician side. I understand in India and many other Asian countries, the situation is very difficult to do this education because one physician has to handle 100 patients in a day, 50 patients in a day. So they don't have enough time to spare for the educational activities for which we can have a separate team which can do this. And now the question, people are so much active on the social media, we can make our videos in our leisure time and put on the social media, which can help many people for keeping themselves in the best possible health condition. Of course, the lifestyle intervention can never be ignored. They are the early implementation for the prevention strategy, and they should be, and they are, and they will remain always. So, need for the unified Asia Pacific guideline, context specific recommendations, addressing resource limitations and regional epidemiology. Pragmatic approach is more important and well needed in solutions of the low resource setting. And that is the thing which is needed in the primary healthcare setting of India. If we can really handle the situation better in primary healthcare, we can take care of their diabetes, we can take care of their hypertension. We don't allow the patient to stop the medication after the normoglycemic and normotensive. Then we can stop the burden which is coming to the tertiary care hospital. Most of the time, we feel very good once a MP donates uh, dialysis machines to some hospital. He has donated 10 dialysis machine, 15 dialysis machine, and they feel proud of that. They have made the cath lab. They have gifted cath lab to our city. Earlier, 20, 30 years before, we were having only one cath lab at All India Institute of Medical Science and followed by another hospital in Delhi and then Puttaparthi. But now every city is having the multiple cath labs and they all are running. So really our strategies towards the disease management is not that what it should have been. We are failing in our strategies. We are not really reducing the disease load to the patient, whatever we are doing. So implementation framework should be more and more stronger. Practical rollout strategies should be implemented, should be made, which should be acceptable to all these Asian Pacific countries who are handling the similar kind of the treatment, similar kind of the population, similar kind of the challenges among their individuals. So monitoring protocols should involve the regular blood pressure checkup, then quarterly screening of the urinary albumin, creatinine, annual assessment by the HbA1c, creatinine, and EGFR, and annual cardiac assessment either by ECG and echocardiography. I prefer that echocardiography should be taken as an annual cardiac assessment for all the patients, because many times we have seen that patient, those who are reaching for the first time to the clinician, already having the diastolic failure. And you cannot many times detect simply doing the ECG and simply doing your blood pressure measurement. This can be needed the echocardiography. The future directions could be looking for the novel biomarkers, and these novel biomarkers are being already in the developing stage. I have talked about these novel biomarkers in the IDF meeting, but we have to work more precisely on these novel biomarkers so that we can detect the individuals in their early days of life that this particular person or this child is going to become hypertensive when he will become the adult, or he is going to be diabetic if he will not be performing the enough exercise and he will not keep control the insulin resistance. Precision medicine that has proven its worth. Not to tell much about that, already many multiple sessions must have been in the Diabetes India about the precision medicine. This is the individualized treatment which should be designed for every patient separately by the clinician's own judgment, concerns of the clinician. Advanced imaging, superior diagnostic modalities should be utilized whenever they are needed. And bariatric surgery should also not be ignored even nowadays. It is option for the refractory cases which are not really being handled well by all options of the medicine which are available to us. So key takeaway message for this triple alliance approach, this should be in the form of the integrated CVD, CKD, metabolic management is essential. Asia Pacific is having the different needs. So this is the urgency of Asia Pacific guidelines, Asia Pacific management protocol, critical need for the improvement in the blood pressure control rates as well as glycemic. Modern therapy should be combined of the RAS blockers, SGLT2 inhibitors with MRA combination strategy. And especially if your patient is not having the hypertension or your patient is having the hypertension well managed by the RAS, then you can choose the MRA trazofendione. So this could be the success formula if we are working with the collaboration of the multidisciplinary approach which should be accessible to each and everyone, guideline driven care. Multidisciplinary approach should not be in a way that patient is coming to my clinic and I am saying that for albuminuria go to the nephrologist and he is going to pay the another fees to the nephrologist, the nephrologist saying go for the cardiologist, so he is running around among so many clinics and he is getting confused and what the treatment should take and what the treatment should not be taken. Currently it is happening only. So we should find some method that it should not happen. Patient should be given the comprehensive care together under the one roof by one combined strategies which could be made, and that can only be the success formula to stop the organ damage, especially those who are having the metabolic multiple diseases together. Thank you very much for your time.